All right, welcome to this explainer. Today we're zeroing in on the absolute high-yield essentials of alpha-1 antitrypsin deficiency. If you're gearing up for the MSRA, you are exactly where you need to be. We're cutting out all the fluff to focus purely on the core genetics, the clinical presentations, and most importantly, those sneaky little exam traps examiners love to use. Let's get you completely confident for test day. Here's our game plan for today. We'll start with the genetics and pathology basics, move into clinical signs and management, tackle those high-yield MS exam traps, and finally wrap things up with a rapid recall quiz to lock it all in. Okay, let's kick things off with part 1, genetics and pathology basics. Now, right out of the gate, do not fall for the classic autosomal recessive trap. This condition, it's autosomal codominant. What does it actually mean for you clinically? It means both alleles are actively contributing to the patient's phenotype. Those mutated proteins don't just hide quietly in the background. They're expressed right alongside the normal ones. This whole process is dictated by mutations in the SERPA1 gene. Definitely burn this inheritance pattern into your memory because it is a massive favorite for multiple choice questions. And this brings us to the dual hit mechanism, which is just absolutely fascinating. Think of alpha-1 antitrypsin deficiency as a systemic protein misfolding disorder, but one that hits two totally different organs in completely opposite ways. In the lungs, the disease is driven by a loss of function. See, A1AD is a serine protease inhibitor made by the liver, and its main job in the lungs is to neutralize neutrophil elastase. Without that protection, uninhibited elastase basically just goes rogue, destroying the alveolar walls and causing panicinaire emphysema. But in the liver, it's a totally different story. Here, it's a gain of toxic function. The mutated A1AT proteins misfold right there in the endoplasmic reticulum of the hepatocytes. And because they're misfolded, they can't be secreted into the blood like they should be. Instead, they clump together into these polymerized, sticky aggregates that just build up inside the liver cells. That buildup causes cellular toxicity, cirrhosis, and heavily increases the risk of hepatocellular carcinoma. So, to put it simply, the lungs suffer from a lack of the protein, while the liver is actively poisoned by a buildup of it. All right, moving right along to section 2, clinical signs and management. So to really grasp how this looks in a real patient, you've got to know your alleles. I love these mnemonics for this. M stands for normal, normal healthy levels and normal function. S is for so-so, meaning just a slight or mild deficiency. And Z, that stands for zero protection. This is your severe deficiency. A patient rocking a PiZZ genotype is at the absolute highest risk for early-onset disease. So how does this actually present? Well, for pulmonary signs, look out for early-onset breathlessness, or COPD symptoms in surprisingly young patients, usually in their 30s or 40s. A huge flashing red flag is if they are non-smokers or maybe just very light smokers. On the hepatic side, the timeline is kind of wild. In neonates, this can tragically show up as prolonged cholestatic jaundice or neonatal hepatitis. Then in adults, it presents as unexplained cirrhosis or chronic liver disease, even, and this is key, in patients who are lifelong non-drinkers. Now, let's talk about what you actually do when you spot this. Step 1 is your initial investigation, checking serum A1AT levels. But hold that thought because there's a massive catch with this test that I'll tell you about in a second. Step 2 is getting that definitive diagnosis. You do this through protein phenotyping or genotyping, using electrophoresis or PCR to pinpoint those specific allele variants like PiZZ. When we get to management, step 3 is all about the lungs. Listen closely. Strict smoking cessation is arguably the single most vital intervention you can make here to stop the rapid decline of their lung function. It's absolute priority number 1, though of course you'll also throw in standard COPD care like bronchodilators. Finally, step 4 is surgical management for end-stage disease. A liver transplant is super interesting here because it literally cures the hepatic defect. The new donor liver will successfully turn out normal A1AT. But, and this is a big but, you have to remember that this shiny new liver does absolutely nothing to reverse the structural damage already done to the patient's lungs. Okay, pay close attention here. Section 3, high-yield MSRA exam traps. Examiners love these. Let's uncover a classic. The lobe trap. If you get an exam question describing a patient with emphysema, the very first thing you should do is check the lobe distribution on the CT scan. Typical smoking-related COPD almost always targets the upper lobes, but alpha-1 antitrypsin deficiency, it heavily targets the lower lobes. A great mnemonic to keep in your back pocket is that A1AD means D equals down, which equals the basal lobes.
Pair that with the age of onset, young folks in their 30s and 40s for A1AD versus older patients in their 50s and 60s for typical COPD, plus the lack of a heavy smoking history, and boom, you've got a classic clinical vignette. Just don't let them trick you. If it's A1AD, always think lower lobes.
And here is trap number 2, the blood test trap. You absolutely cannot forget that alpha-1 antitrypsin is an acute phase reactant. This means that during a chest infection, any systemic inflammation, or even during pregnancy, the body naturally ramps up its production. So imagine your patient comes in wheezing with an acute exacerbation, and you test their serum A1AT. The levels might artificially spike right up into the normal reference range, completely masking a severe underlying deficiency. If your clinical suspicion is high, a normal serum level during an infection does not rule out the disease. You've got to look at the genotype or phenotype.
All right, time to see what actually stuck. Let's jump right into Section 4, the MSRA Rapid Recall Quiz. Think fast as we go through these. Question 1. What is the exact genetic inheritance pattern of alpha-1 antitrypsin deficiency? Got it? It is autosomal codominant. Both alleles are actively pulling their weight to create the phenotype. Question 2. You've got a 42-year-old lifelong non-smoker with progressive breathlessness. The CT shows panasonar emphysema. Which lung zones are predominantly affected? Remember our mnemonic, D equals down, so the answer is the lower lobes. Question 3. A patient with a severe PIZZ genotype comes in with acute bronchitis, but their serum alpha-1 antitrypsin level comes back totally normal. Why is this misleading? Yep, because A1AT is an acute phase reactant. The inflammation is artificially inflating those levels and hiding the true deficiency. Question 4. After a highly suspicious clinical presentation, what specific lab test do you actually need to definitively identify variants like PSZ or PZZ? A basic blood test won't cut it here. You need protein phenotyping or genotyping using electrophoresis or PCR. Question 5. What is the underlying cellular mechanism causing the liver damage in this disease? Think back to that dual hit slide. It's the buildup of polymerized, sticky mutant proteins inside the endoplasmic reticulum of hepatocytes. It is a toxic gain of function. Question 6. Which specific protease enzyme is normally neutralized by A1AT in the lungs to stop elastin degradation? It's neutrophil elastase. Without A1AT, that elastase just runs completely wild. Question 7. What specific morphological type of emphysema is classically linked to this deficiency? You should immediately be thinking of panasonar or panlobular emphysema. Question 8. What is the single most vital lifestyle intervention you can order to slow the rapid decline of lung function in these patients? No fancy meds here. The number 1 answer is strict, absolute smoking cessation. Question 9. Let's say your patient gets a successful liver transplant. Does this cure their coexisting pulmonary emphysema? The answer is absolutely no. A new liver gives them normal A1AT, sure, but it cannot reverse the structural damage already done to those lungs. Question 10, our final rapid fire. How does liver involvement in A1AD classically show up during the neonatal period? Tragically, this presents as prolonged cholestatic jaundice or neonatal hepatitis. So I want to leave you with a final thought to really ponder. We know a liver transplant fixes the A1AT factory but leaves the lungs permanently scarred. So looking ahead, could future genetic therapies actually correct the SERPINO1 mutation itself, completely reversing both sides of this dual-hit disease simultaneously? The science is moving incredibly fast, and who knows what treatments you'll be prescribing a decade from now. I really hope this explainer has you fully primed and ready to dodge those exam traps and completely crush your MSRA. Keep at it, and I'll catch you in the next one.